welcome to all delegates. And sir, I am very privileged and I bid my very heartfelt thanks to you, sir, for giving me this opportunity to speak on this forum. So without wasting time, I am just starting my presentation. It is about blood gas analysis, which is actually looks very perplexing, very confusing. So we want to avoid this. But I will try my best so that it has become a very cup of tea for everyone. So I am sharing my presentation. It is visible, sir?
Full slide.
Yes, sir. So the topic of my presentation today, it is the third lecture of this online lecture series. So we have dealt with the oxygenation as well as carbon dioxide physiology. So the next part we will discuss, after knowing that much of knowledge, how to understand and how to go for the sample, how to understand the pathophysiology or the basic physiology of arterial blood gas. So myself, Dr. Anindya Saha, Associate Professor, I am starting my presentation. So the outline of my discussion will be what is ABG and what are their indications, a bit about acid base and oxidation ventilation physiology, something about blood gas machines and the parameters which are there in the strip of the ABG reports, how to interpret them, and what are the sample sites and the methods. There will be some sampling errors which are very important to know, and we have to take precautions to avoid those things, otherwise the report will be fully erroneous. And finally, knowing everything this, we will know the approach how to interpret our blood gas, and at the last we will discuss some examples, some exercises, as well as some special situation. So what is an ABG report? ABG stands for arterial blood gas. It is a point of care test. I would like to emphasize, it is a point of care test. It is not done in the laboratory. It is done at the bedside laboratory to measure the level of oxygen and carbon dioxide in the form of partial pressure as well as blood pH level, which is an indicator of the acid-base physiology or the hemostasis of our serum or blood or plasma. And we preferably rely samples taken from a peripheral artery. So it is gold standard tool to measure the acid bed changes of a sick neonate, and it helps to assess ventilation of the lung in form of carbon dioxide and oxygen exchange, and thus helps to fix the change in the ventilation parameter, either it maybe is on the invasive or non-invasive mode of ventilation. Simultaneously, we'd also like to, if we like to assess the perfusion of the sick neonates, we always rely on some parameters in the blood gas like base excess or deficit, bicarbonate, pH, and recently the emphasis has been given on the lactates. So what is the physiology of arterial blood gas? We have to know four equations. It is Henderson-Hasselbalch equation, which is the most crucial, and the other three are already has been discussed, so I will not touch them. Those are PCO2 equation, alveolar gas equation, and oxygen content equations. So let us see how acids are produced in our body. So we take nutrients and energy is synthesized, which is required for tissue synthesis and function of the body, and storage. There some energy is also kept in the storage form, and simultaneously we create some or excrete some waste products. Of these, 98% are in the form of volatile acids, that is in form of carbon dioxide and its other form. So the form may be carbon dioxide or maybe H2CO3, that is carbonic acid. So this is the major form of our waste product. And the other products are non-volatile acids like inorganic acids or organic acid, Inorganic acid includes sulfuric or phosphoric acid. And another important is lactic acid, which is a byproduct of anaerobic or hypoxic situation, and some ketoacidosis in case of diabetic or some other diseases. So these are the products, waste product, which governs or regulate or dysregulate the pH system or the acid-base system of our body. So basically, this acid-base physiology is maintained or dictated by hydrogen ion concentration. And intracellular function in a narrow range of hydrogen ion concentration, they can operate. So if we express hydrogen ion in their molar or nanomole quantity, that will be inexpressible. So we express it in form of some negative logarithm, which is known as pH. So let us see if in a neutral situation, when we know the pH is 7, the actual hydrogen ion concentration is 10 to the power minus 7 millimole per liter. And we come to pH if we have a negative logarithm of this 10 to the power minus 7. So if it decreases to 10 to the power minus 8, that is 1 by 10, the pH become basic. So it comes to 8. Similarly, 10 to the power 9 equivalent to pH of 9. Whereas in the acidic range, if the H ion concentration increases from 10 to the power minus 7 to 10 to the power minus 6, that is tenfold increase. So pH decreases from 7 to 6. So more hydrogen ion concentration, so pH will be more towards acidic range, from 7 to 6 to 5. So this way, hydrogen ion concentration is represented as pH of our body. But our body has to maintain a very good regulatory system, which is known as a buffer system. So buffer system, basically there are three buffer. One is buffering by the hemoglobin. So another buffer exists in the respiratory system in form of weak acid, that is a carbonic acid, as well as bicarbonate. And another buffer is again in the renal system. That is again by combination of carbonic acid and bicarbonate, or some other phosphate buffer and other buffer. But just to emphasize, the 80% of the pH control is done by carbonic acid buffer. So actually the pH is regulated, the concentration of bicarbonate and carbonic equilibrium in our body. Similarly, there is another advantage. The carbonic acid buffer also goes into form of volatile carbon dioxide. By this, those acids can be eliminated from our body. So for this reason, the weak acid known as carbonic acid is very important for our acid-base regulation. So if we go by the Henderson-Hasselbalch equation, it is the dissociation of carbonic acid into H plus and bicarbonate, which is the key reaction which governs the pH of our body. So pH of the blood depends on this dissociation and the buffer equilibrium. So here is the calculation how H2CO3 is dissociated into H plus and H3CO minus, which is again depends on the dissociation constant known as K. So K is equal to H plus ion into H3CO3 divided by carbonic acid concentration. If we have the log of K, so the equation will be log K is equal to log H plus log of this ratio. And if we take the negative logarithm of H plus ion by changing the both sides of the equation, so it will be minus log H plus is equal to minus log K plus log of this ratio. So it is again minus log H plus is known as pH. So pH is equal to pK plus log of bicarbonate and carbonic acid concentration. Again, carbonic acid concentration can be expressed by the amount of PCO2, which is measured in the direct ABG machine, and S, which is the solubility coefficient. So this dictates the pH value And this is how the pH is estimated from bicarbonate and PCO2. So this is the clinical equation, whereas pK, log of pK is equivalent to 6.1 and the log of whole things HCO3 minus divided by 0.03 and PCO2 will be estimated, and finally we will get the pH of the system. So there are the other equations like PCO2 equation, how the PCO2 is measured, or it depends on the tidal volume, respiratory rate and the dead space volume. Again, the different oxygen and carbon dioxide partial pressure in different type of gases like inspired air, alveoli air, on the blood and in the tissues, and the oxygen content equation, that is the total oxygen content, how it is calculated. It is equivalent to hemoglobin into 1.34 ml into saturation in decimal plus 0.003 ml into partial pressure of oxygen. It is also expressed in the ABG paper. So this is how they are estimated this. This is the oxygen content equation, which altogether gives a value of saturation, partial pressure of oxygen and dissolved oxygen. This is the alveolar gas equation. It helps us to know the partial pressure of oxygen in the alveolar air, and it is actually essential for estimation of alveolar and arterial oxygenation difference. So knowing all these things about the physiology, I will directly highlight or emphasize what are the indication in NICU or neonatal unit for which we will require a blood gas. So if there is a ventilated neonate or a neonate with respiratory distress, we would like to know about the oxygenation and ventilation status by knowing the value of PCO2 or PO2. So blood gas is required. So we would like to also know the tissue perfusion, which will be expressed by lactate and bicarbonate and base excess. If there is acute deterioration in the ventilated baby, then also we would require a blood gas. In case of non-ventilated neonates, if the baby is with shock or there is sepsis with shock, suspected metabolic disorder, which will be baby will have some accumulation of non-volatile acids. If the baby is having failure to thrive or ongoing weight loss or no weight gain, perinatal asphyxia, where therapeutic hypothermia is required or not, and suspected RTA, these are the major conditions where we would like to know the acid-base assessment. Next, I will discuss about the machines and the parameter. So, the traditional ABG analyzer, there are some electrodes which will estimate directly pH, PCO2 and PO2. Those electrodes constructed of a permeable membrane, and they will have a bathed by a solution, and that solution will be passing H plus ions, carbon dioxide and oxygen from bloods or samples, and they will react with the solution, create a voltage change, and those voltage change will be estimated by the electrodes, and that will be transformed in form of measurable chemical change. And some newer analyzer will use techniques like potentiometry, fluorescence, and some ion selective electrodes. And we require very minimum sample like 65 to 150 microliter, that is equivalent to 0.06 ml to 0.1 ml of blood, obviously arterial blood. So overall, our machine will measure pH, PCO2 and PO2, and they will derive some calculate the rest of the parameter like actual base excess or standard base excess, bicarbonate, total carbon dioxide content, SpO2 or SaO2, total oxygen content, alveolar to arterial oxygen difference, and arterial alveoli oxygen ratio. So the information we have to provide to the machine is hemoglobin, temperature, and FiO2. Most of the machine by default will be set on the temperature of 37.5 37 degrees centigrade. But for FiO2, if we do not add anything, they will calculate on the basis of 21% of the FiO2 and hemoglobin of a fixed hemoglobin of 14 to 15. But if my baby is on ventilator with a higher FiO2 or a lower or higher hemoglobin, then the result will not be related or cannot be reliable for that particular baby. So in those cases, we have to feed the machine with hemoglobin and FiO2. So this is a common strip of a ABG paper, and we can see there is some acid-based physiology and the blood oxygen and carbon dioxide level, like in form of pH, partial pressure of carbon dioxide, oxygen, bicarbonate actual, bicarbonate standard, base excess of the extracellular fluid, which is also known as base excess standard, and some total carbon dioxide level. Additionally, there are some co-oximetry which will analyze different components of hemoglobin as well as direct saturation, the hemoglobin saturation of the blood, and some electrolytes, and finally lactate. So these are the newer machine which will give a holistic report. So first, if we go by the acid-based physiology, it is the bicarbonate which will be calculated. So already I have discussed the bicarbonate will be calculated from this equation 6.1 plus log of bicarbonate divided by 0.03 into partial pressure of carbon dioxide, and these two values are already estimated by the machine, and bicarbonate will be derived from the machine. So bicarbonate is dependent on the partial pressure of carbon dioxide of the baby. So this is known as actual bicarbonate, and it is the value which is the standard value is 20 to 24 milliequivalent per liter, and if we call it acidosis when it is less than 20 and alkalosis when it is more than 25. So less bicarbonate means acidosis and more bicarbonate means alkalosis. There are other metabolic components which are independent of partial pressure of carbon dioxide. This is known as standard bicarbonate, actual base excess, and base excess of the extracellular fluid or standard base excess. So standard bicarbonate, that is 20 to 24 milliequivalent per liter is the standard value, but here the blood has been calibrated to the PCO2 of 40. So in case of actual bicarbonate, if the bicarbonate level, carbon dioxide level is higher, so those results cannot be reliable. So in those cases, the machine has calibrated the bicarbonate to the extent of PCO2 of 40 millimeter of mercury, and they have calculated the standard bicarbonate. So similarly, if standard bicarbonate is low, so it represents it is pure metabolic component without respiratory effect, and if it is high, it will show pure metabolic alkalosis without any respiratory involvement. Second is the buffer base. So we know there are different type of buffer. The major buffer is bicarbonate buffer, which contributes around 24 milliequivalent per liter or millimole per liter, and other two buffer are hemoglobin buffer and protein buffer. Altogether, the buffer base is 48 to 50 millimole per liter. So it is the total amount of buffer in the body. So, but buffer in the blood is corresponding to buffer total of 48 to 50 millimole per liter. So, if we consider base excess, that will consider it is the excess buffer base in addition to the total buffer base. So if the total buffer is 48 to 50, if the total buffer now increase up to 54, then it is showing the base excess. So it is known as actual base excess. So it can be plus 346 or it can be less than total buffer base, like less than 48, like in form of 45 or 44, then it will show the negative value. So it will be in either we can say it base excess minus 3 or we can call it base deficit. So normal value is minus 3 to plus 3, but in some reference books it has been also told healthy neonate it should be in between minus 1 to plus 3. But in case of preterm, the preterm are having more metabolic acidotic milieu. So the preterm neonate, the buffer base excess, it is normal to have a negative side, like minus 8 to plus 2. So this is known as actual base excess. So it refers to base excess or deficit in above or below from the total buffer base, which will require to make 1 liter of blood to the normal pH of 7.4. So low bicarb means base deficit. Here, all the hemoglobin and bicarbonate are taken into consideration. But if we consider standard base excess, it will consider hemoglobin of only 5 gram per dl. So again, it will consider pure metabolic component. But for all practical purpose, we consider the actual bicarbonate and the actual base excess for our daily interpretation. Next is the blood oxygen and carbon dioxide parameter. So it normally knows it is the partial pressure of oxygen and the normal values is 50 to 70 millimeter of mercury, and it is directly estimated by the blood gas machine. And the problem is that already if as the 50 to 70 millimeter of mercury is corresponding to the normal saturation of the hemoglobin, it is equivalent to 95% of the hemoglobin saturation. But this partial pressure of the oxygen is partial pressure of the oxygen exerted by the only dissolved oxygen in the plasma, whereas the saturation is the estimation of oxygen attached to the hemoglobin. But those two are not, those two are related but are not expressing the oxygen of the same type of oxygen molecule. So an SpO2 of 100% can correspond to the partial pressure of oxygen ranging from 80 to even 300 millimeter of mercury. So SpO2 less than 70 or less than 75 can indicate a lower partial pressure of oxygen, but SpO2 more than 95 to 100 does not necessarily mean the oxygen pressure is limited up to 50 to 70 millimeter of mercury. So it can happen in place of hyperoxia also. So dangerous hyperoxia can be coexistent. So it is always essential to have a partial pressure of oxygen estimation even if we know the saturation by non-invasive method. Another method is total oxygen content. Already it has been discussed. It is hemoglobin into 1.34 ml into saturation in decimal plus 0.003 into partial pressure of oxygen, and it is expressed as a volume percent per ml per 100 ml of blood or plasma. So partial pressure of oxygen corresponded to very little amount contributing to the total amount of oxygen, but it is only dissolved oxygen in the plasma which is available to enter cell for respiration. So that's why partial pressure of oxygen is very important to know. Next is the calculation of alveolar to arteriolar difference of oxygenation. It is first alveolar oxygen concentration is measured. It is measured by the formula of FiO2, barometric pressure minus pressure of the water pressure into FiO2 minus partial pressure of carbon dioxide divided by respiratory quotient minus partial pressure of oxygen. So if the baby is in the room air, it is 760 minus 47, that is the water pressure, into 21, that is equivalent to 0.21. So that is equivalent to 713 into 0.21, that is again equivalent to 150. And this part is the partial pressure of carbon dioxide. If the baby is having partial pressure of carbon dioxide of PaCO2 of 40 and the respiratory quotient is normally 0.8 to 1, so it is 40 divided by 0.8, it is almost 50. So 150 minus 50, it is 100 millimeter of mercury. So in a room air, if the baby is having 21% saturation, 21% oxygen, and having a carbon dioxide pressure of 40, the oxygen PaO2 is around 100. But if the baby is having 50% of FiO2 of similar carbon dioxide pressure, it is 311 millimeter of mercury. And the if PaO2 is 150, then the difference is 161 millimeter of mercury. So if AaDO2 is dangerously high, that indicates baby is having some severe disease like ARDS or something like that. Next component is PaCO2. So normal value is 35 to 45 millimeter of mercury, and it indicates only alveolar ventilation. If PCO2 is less than 35, it is respiratory alkalosis, and if it is more than 45, it is respiratory acidosis. And similarly, there should be another component, total carbon dioxide content, that is 23 to 27 millimole of carbon dioxide or bicarbonate molecule divided by liter of blood, and in venous blood it is 2 to 3 millimole of liter, and it is the sum of bicarbonate and carbon dioxide. And let us see the formula. It is the amount of millimole of bicarbonate plus dissolved carbon dioxide into 0.03. That is, if the bicarbonate level is 24 and the carbon dioxide PCO2 is 40, then the TiO2 is 25.2 by this calculation. So this is the summary of all the related nomenclature. I will not going to repeat all these things. Now coming to the most important part, how to take ABG samples. So these are the proper samples which are commonly used. One is arterial staph sample, that is the arterial puncture sample. That is very painful, but it is ideal to have a arterial blood, but it is not very pragmatic. Second one is if we do not stab repeatedly, but instead of that put an arterial catheter like AC catheter or peripheral radial artery catheter. The other arteries are not permissible to go for cannulation in case of neonate. The most pragmatic one is arterialized capillary sample, that is the capillary sample from the heel prick, and it is made to act as a similar way like the arterial blood. And last one is the venous sample, though it is less reliable, but it is most oftenly used in the busy NICUs because the venous blood is often taken for other purposes, and we often calculate or estimate some important parameters from it, though the most of the other parameters like oxygenation and carbon dioxide level are not very reliable in the venous sample. So let us see one by one. So arterial puncture samples are taken from the radial and umbilical. It is contraindicated to stab or puncture femoral, brachial or dorsalis pedis. Modified Allen test must be done before radial artery puncture, and we should use very minimal amount of heparinized saline while we are taking this sample from any arterial puncture, and we always expel all amount of air, cap syringe immediately and process immediately. So this is how we are place the hand of the baby in the dorsiflexion, and then we do the modified Allen test where we will compress both the radial and ulnar artery. Then we release the ulnar artery and to see whether there is the permeability and the circulation is patent in the radial artery, and then we compress the ulnar artery to see whether the radial artery is patent, and if both the artery is patent and there is any flushing of the skin, then we are very happy the palmar arch is circulating. Then we can stab one or puncture one artery. Otherwise, in case of incompetence or any blockade in the artery, it is very dangerous to puncture because of the blockade of the artery and gangrenous change in the hand. So this is how it is punctured, and this is how we permanently put a radial artery line. So if we want to keep a line, that should be very cautious, because we cannot put any drug, even mistakenly or erroneously, that will make a damage to the hand, and we will continue with a heparinized solution. So the cannula to be taped and secured with very dynaplast, and it has to be mentioned that it is an arterial line. There should be one three-way for flushing, as well as to remove the dead space solution and to have a direct free flow of blood for arterial sampling, and we have a running heparinized NS solution. So it has to be connected with an heparinized solution with a concentration of heparin 1 unit per ml, and the rate should be as low as 0.5 to 1 ml per hour. And in case of ELBW, it can be 0.25 unit per ml per concentration. And while withdrawing the blood, we have to remove the blood plus fluid 4 times the dead space, which is very important. Otherwise, the erroneous, the solution containing blood and the heparin solution will be coming into dilution, diluting the blood sample. And we are taking the sample and then again putting the blood mixed solution into the mainstream aseptically, so that blood loss is not there. This is how we are taking the heel prick arterialized capillary blood. In this process, we first have to warm the heel, and we have to make the heel warm by warm compresses, and nowadays some exothermic chemical packs are available. We must prick only the medial or radial aspect, not over the calcaneum. We have to avoid the posterior curvature. We have to clean the site with all precaution and allow it for drying, and then wipe away the initial drop of blood, and to have a gentle droplets of blood. And we have to take the blood in a pre-heparinized capillary tube to feel drop from the tissue, so that there will not be any sucking of the air within the blood column. Then we have to rotate the sample to mix heparin oil, and we have to use some procedural analgesia in form of either dextrose or express breast milk. There are some technical challenges for this capillary sample, because if there is inadequate warming, that will give poor tissue perfuse blood, that will give falsely elevated PCO2. If there is exposure to blood to the air, that will increase PaO2 or falsely decrease PCO2. There is a chance of calcaneum injury, and if we excessively squeeze it, then again there should be contamination by tissue fluid or venous blood. But in spite of all these things, if the baby is having a prolonged stay and needs repeated sampling, it is most useful for chronically ventilated infants. The most non-dangerous or innocuous sampling is the venous blood sampling. It is useful for only bicarbonate and base excess estimation, and we may also have a rough estimate for pH and PCO2, though there is some guideline. The pH and PCO2, pH may be something lower than the normal and PCO2 may be higher than the expected value, still can be reliable, but for bicarbonate and base excess, it is very reliable. So to have an estimation about the tissue perfusion, the venous blood sample can be used, and obviously it is less painful. So we can have a comparison of ABG or blood gas at different sites. The gold standard is arterial and the capillary is fair, but for venous sample, pH will be lower than the standard. PO2 is never reliable. PCO2 is somewhat higher than the arterial value, but bicarbonate is fairly comparable. So it is reliable for bicarbonate, but have a good guess about the pH and PCO2. There is every chance of sampling error, and we have to maintain some precaution. So first thing, we have to be very cautious about the use of heparin in the syringe where we are taking or we are using while drawing the blood sampling. So we use the low strength heparin. So never we have looked about the heparin concentration which is supplied at the word. Most of the cases it is, we have seen, it is the, if we do not ask for specifically, it is 5000 unit per ml supplied, but that will increase the heparin concentration in the as a diluent. So that will erroneously increase the amount of heparin, which will erroneously represent the change the value. So we must use the heparin concentration of 1000 unit per ml. The first, while preparing the syringe, we have to draw very minimal amount of heparin in the syringe only, just to coat the wall of syringe and to evacuate the syringe completely by repeated flushing before drawing the blood sample. So we have to make syringe free of any visible heparin. So what will happen if there is excess dilution of heparin? So ideally keeping heparin value 5% or less than the sampling value. Otherwise, there will be significant error in the reading. Or otherwise, the sampling may be collected in a heparinized capillary from the hub of the needle. So if there is a heparin dilution, the pH will be decreased, the PO2 will be increased, the PCO2 will be decreased, the bicarbonate will be decreased, the base excess will be decreased, and one thing is very important, if we have a electrolyte simultaneously, the ionic calcium level will be significantly reduced. So we never use excess heparin while doing the or taking the sampling in a syringe. We have to process the sample immediately because blood is a living medium and there is a change due to metabolism that will increase the carbon dioxide or decrease the oxygen immediately if we continue to keep it or keep it aside. So it has to be processed immediately, at least within 30 minutes. If again it has to be kept for later, it has to be kept in the freezer within the slush of ice. And when it will be taken out, it will be again shaken, homogenized, and expel a few drops before processing. So with the temperature, normally, if the sample is kept in the skin temperature or in the body temperature, the pH will be decreased by 0.01 in every 10 minutes. PCO2 will be increased and PO2 will be decreased. But if we keep in 4 degrees centigrade, then the temperature, the change of pH, PCO2 and oxygen will be very minimum. So that's why if at all it has to be kept for future estimation, it will have to be kept within the fridge. Next important thing, often we neglect, it is the contamination by ambient air. Often there is a air bubble within the syringe. If the air bubble is there, so it will contaminate the blood gas sample falsely. Why? How? Because the room air has a PCO2 negligible, whereas the blood gas has a higher PCO2. So it will lower the PCO2 concentration of the sampled blood. Again, if the PO2 of the room air is normally 150 and if the original value is below 150, erroneously it will show a higher PO2, and if the original value is above 150, it will show a lower PO2 due to the diffusion effect. So that's why any air bubble in the blood sample will cause erroneous result. So we have to expel the air, avoid bubble, tighten the cap, and to process the blood immediately. So this is the normal neonatal ABG value. So there are somewhat difference in different reference frame. Normally pH is 7.35 to 7.45. The PCO2 is 35 to 45. PO2 is 50 to 70 millimeter of mercury. Bicarbonate is 20 to 24 milli equivalent per liter. And base excess in somewhere it has been told plus minus 2 to plus minus 3. And in case of Peter, it is plus minus 5 it is acceptable. So now is the crucial part, how to interpret the ABG strip. So before we analyze, we have to know this language or terminology. Do we know less than 7.35 is acidosis, more than 7.45 pH is alkalosis. PCO2 increased is known as hypercapnia. PCO2 less than 35 is known as hypocapnia. And there are disorder known as primary acid-base disorder and mixed acid-base disorder. So if there is pH changes is corresponding with the either only bicarbonate changes, then it is known as direct or primary metabolic disorder, and pH changes is related to the CO2 changes, then it is known as primarily respiratory disorder. And there are some compensation that will be discussed, but if there is together more both metabolic and respiratory disorder, then it is known as mixed disorder that will be discussed in details. So there is stepwise approach to ABG interpretation. First, we have to identify the abnormality in pH. Then we have to compare the changes in the PCO2 with the pH. So if we can identify if pH is acidic or alkali, then we have to understand or relate whether it is related to PCO2 change or it is related to bicarbonate change. Again, if we can decide it is related to pH and PCO2 or pH with bicarbonate, then we have to correlate the change between PCO2 and bicarbonate in between. And finally, we have to check the compensation status. Lastly, we have to calculate the anion gap if metabolic acidosis is present, and we have to check for oxygen status if we want to know the PaO2 and AODO2. So let us go one by one. So check first, before estimating or going for an estimation of acidosis or alkalosis, we have to know whether the machine is giving the correct pH. So there are pH value, there are PCO2 value, there are bicarbonate value. So by using the calculator, there are online calculator is available. We can cross verify the pH from bicarbonate and PCO2 with the pH given by the machine. Like if the PCO2 is 30 and bicarbonate is 14 milliequivalent per liter, from this equation pH is equal to 6.1 plus log of bicarbonate divided by 0.03 into PCO2, we can deduct it is 6.10 plus 1.19. So it is equivalent to 7.29, which is again equivalent to the estimated pH of the machine. So the machine has got an internal validity. So the machine is reliable. Again, we can cross verify from another calculator by calculating the number of H plus ion from PCO2 and bicarbonate. So again, the PCO2 is 30 millimeter of mercury and bicarbonate is 14. So that gives rise to the value of bicarbonate 52 into 10 to the power 9 minus 9 millimole per liter. And if we use the online calculator, this will give pH of 7.28. This is calculated value, but machine is directly estimating the pH, which is just equivalent to the given calculated pH of 7.28. So this indicates the machine is reliable. So this is the checking for consistency. So after checking for consistency, we will see whether it is acidosis or alkalosis. So it is very simple. pH less than 7.35, it is acidosis. pH more than 7.45, it is alkalosis. Simultaneously, we can see whether it is hypoxemia or hyperoxemia or normoxemia. So it is initially we will like to see only whether it is acidosis or alkalosis. Next, we will see whether it is related with the change in the PCO2 or not. So if we see there is acidosis and there is increase in the carbon dioxide, so this acidosis can be explained by PCO2 value. So this is known as respiratory acidosis. Here, the direction of change in the pH and direction of PCO2 is inverse. So pH is lowered, whereas the PCO2 is higher. And we can change the, we can estimate the value also. 12 millimeter of mercury of PCO2 change from 40 will change pH by 0.1 in the opposite direction. So in this case, here the change in the PCO2 it is, I am showing in the previous example, the pH is 7. If the pH is 7.3 and the PCO2 is 65, then the PCO2 is increased by 25. So we will expect to decrease 0.2 in the opposite direction in case of pH. So pH is expected to have 7.4 to 7.2. So we have to see whether the pH is 7.2 or not. If this is matching, then there is respiratory acidosis, and then the value is matching also. So this way we can see whether the PCO2 change is comparable with the change in the pH. Again, if there is alkalosis 7 point more than 45, and if the PCO2 is less than 35, we can directly call it respiratory alkalosis. If it is not corresponding with the PCO2 value, then we have to see whether the pH change again less than 7.35 is matching with metabolic acidosis or not, which is bicarbonate less than 20 milliequivalent per liter. If it is matching, then it is metabolic acidosis. If pH is more than 7.45 and there is metabolic alkalosis, then bicarbonate is more than 24, it is known as metabolic alkalosis. So the direction of the change in the pH and direction of bicarbonate is in the similar direction. So pH is decreasing, bicarbonate is also decreasing. pH is increasing, bicarbonate is also increasing. And we can estimate the adequacy of the change with this formula. It is the 6 milliequivalent change in the bicarbonate will change the pH by 0.1 in the similar direction. So if we want to locate the primary abnormality, in case of respiratory acidosis, if there is PaCO2 is high, it is respiratory acidosis. If the alkalosis along with PaCO2 is low, it is respiratory alkalosis. And similarly, if the acidosis with low bicarbonate is metabolic, if it is high bicarbonate, it is metabolic alkalosis. I am repeating because this concept has to be internalized very clearly. So here we are looking at the PCO2 or bicarbonate change separately to match with the change in the pH. Now, there are two concepts. Either it could be simple acid-base disorder or it is the mixed acid-base disorder. So in these cases, we have to now, we have already identified which is the primary pathology, whether it is metabolic acidosis or alkalosis, or it is respiratory acidosis or alkalosis. Then we have to see whether the change in the bicarbonate and carbon dioxide can be correlated. So let us see. So we start with the metabolic acidosis. So in case of metabolic acidosis, normal response is pH is low and primary change is bicarbonate is low. Similarly, if we see PCO2 is also low or normal, so there are direction in the unidirectional, so it is simple acid-base disorder. Is it clear? So in case of metabolic acidosis, primarily if bicarbonate is low and along with that PCO2 is low or normal, it is simple metabolic acidosis. Similarly, in case of respiratory acidosis, primarily the PCO2 is high, the bicarbonate is higher or normal, then the direction is unidirectional, then we can call it simple acid-base disorder. Alternatively, in case of metabolic acidosis, if the pH is high and the bicarbonate is high, along with that the PCO2 is higher or normal, we can call it primary or simple alkalotic metabolic alkalosis. And if the respiratory alkalosis is there with low PCO2 and low bicarbonate or normal bicarbonate, we can call it simple respiratory alkalosis. So in these cases, if the primary change is identified and if we can document the secondary change is also in the same direction or in the normal value, then we can call it simple acid-base disorder. But if we see the primary change can be any one of the two. Either it is PCO2 is high and along with very low pH, so it is respiratory acidosis, but bicarbonate is also low. So these are opposite direction. So it is maybe primary respiratory or primary metabolic, but this is a mixed disorder. So in a mixed disorder, the pH will be low. In case of acidosis, PCO2 will be higher and bicarbonate will be lower. So in case of mixed respiratory and metabolic acidosis, pH is very, very high and PCO2 is low and bicarbonate is low. So both change will be in the opposite direction. So there is change in the opposite direction. So this thing I want to make it very clear what is mixed acid-base disorder and what is simple acid-base disorder. So just have an example. So in case of simple disorder, suppose we start with pH of 7.23. So it is less than normal. So it is acidosis. So in case of which one is less than average? So it is 14 is less than average. So it is primarily metabolic acidosis. But in these cases, PCO2 is also lower. So the change is in the same direction. So it is simple acid-base disorder and simple metabolic acidosis. In the second example, if the pH is 7.51, it is alkalosis. It is matching with what? Bicarbonate portion. It is beyond normal value, 20 to 24. So it is metabolic alkalosis. So it is primarily metabolic alkalosis. But if we look at the PCO2 value, then it is in the normal range. So it is simple metabolic alkalosis. Again, in this third example, pH is low, but here bicarbonate is to be not seen. Here PCO2 has to be seen earlier because it is too high. So it is in the respiratory acidotic range. So primary disorder is PCO2 high. So it is primarily respiratory acidosis, whereas bicarbonate is higher. So the direction is in the same direction. So it is simple respiratory acidosis. In the last example, it is alkalosis and it is respiratory alkalosis, whereas bicarbonate is lower. So there is in the similar direction. So it is primary respiratory alkalosis. So these are the example of simple disorder. But in these cases, if the pH is 7.10, so it is acidosis. So PCO2 is high, so there is respiratory acidosis. Bicarbonate is also low, so there is also metabolic acidosis. So this is the example of mixed acidosis, respiratory and metabolic. Similarly, in example of 7.5, it is alkalosis, whereas bicarbonate is also high, PCO2 is also low. So it is both respiratory and metabolic alkalosis. So this is known as mixed metabolic alkalosis. So if there is now simple disorder where the direction is unidirectional, we have to see whether there is compensatory change or not. So in the previous example, when the PCO2 is higher, primary problem, the bicarbonate is also higher. That means there is a compensatory metabolic alkalosis. So the change is in the similar direction. So it is in the simple disorder, but it is showing some compensation. So in the simple disorder, it may be compensated, may not be compensated. So it may show that bicarbonate is in the higher range, so it is showing in the compensation, or it is in the normal range, so it is not showing in the compensation. Again, when the respiratory alkalosis occurs, so PCO2 is low, metabolic acidosis is occurring, so it is also showing compensation. So the secondary change in the same direction along with the primary change in the simple acid-base disorder is always due to the compensation. So here is the example. So in first example 7.30, primary problem is respiratory acidosis, whereas the metabolic alkalosis is the compensation. Whereas in the 7.50 metabolic alkalosis, the respiratory acidosis is the compensation. So these way compensation occurs. Here again in the example, the primary one is the metabolic acidosis, where the respiratory component is compensated by decreasing the PCO2 level. So it is respiratory alkalosis showing compensation. Again, in case of metabolic respiratory alkalosis, it is showing metabolic acidosis as a compensation. So either the metabolic part is compensated or the respiratory part is compensated. So the useful rule is that if the bicarbonate and carbon dioxide are in the opposite disorder direction, think of combined or mixed disorder. So next you have to see whether this compensation is adequate or not. So if the primary, there are few formulas, so it is a tedious job. So you can calculate for the compensation one by one, but primarily you have to identify whether there is a mixed acid-base disorder or it is going to be compensated. So if you can sure up to that, then additionally you can go whether that compensation is adequate or not. So this is the on the right hand column, it is the expected compensation. Like if there is metabolic acidosis, always there will be low bicarbonate. So the low bicarbonate, the amount of bicarbonate total into 1.5 plus 8 plus minus 2 is will be the equivalent PCO2. So if it is less than that, then it is more than that, then it is not adequately compensated. It is matching, then it is fully compensated. Again, in the metabolic alkalosis, we can having now the how the bicarbonate, here we are using total bicarbonate, but here delta sign means the difference of bicarbonate. Here we are seeing whether the bicarbonate, the level of difference of bicarbonate from the value of 24. So whether it is below 20, above or below 24. Suppose the bicarbonate value is 30, so the delta bicarbonate will be 6. So the PCO2 will be 0.6 into 6, that is 3.6 plus 40. So it will be 43 or more. So if the PCO2 is on the level of that, then it is adequately compensated. If it is not to that value, then it is not that compensated. Again, in the respiratory primary problem in respiratory acidosis, then bicarbonate increases by 1 in case of acute cases for each 10 millimeter increase in the PCO2. So if the PCO2 is increasing, bicarbonate is also increasing. So for compensation. And in case of chronic acidosis, the bicarbonate increasing will be higher. Similarly, in the alkalosis, the for 10 millimeter decrease in the PCO2. So here the level of the PCO2 will be seen reference frame as 40. So this increase or decrease will be calculated from 40. So for 40 decrease of 10 millimeter from 40, so for each 10 millimeter decrease, the bicarbonate will be low by 2 from the normal value in case of acute compensation. But in case of chronic compensation, there will be very low bicarbonate, like 4 to 6, fall by 4 to 6 milliequivalent per liter in case of 10 millimeter, each 10 millimeter decrease in the PCO2. So that is for the calculation. So you have to keep this in your hand or in the as a signage on the wall of the NICU or as a signage. Then you can see calculation after getting each ABG report. So we have to remember compensation never reaches or overshoots the normal pH. So most of the cases compensation is partially or near total compensation. So it is not fully compensation. So if the compensation is different from the expected compensation, it is either told as a partially compensated or additional acid-base disorder. So example, so if the pH is 7.28, PCO2 is 30, bicarbonate is 14. So let us see, it is a primary metabolic acidosis. So hence it is both in the same direction. Bicarbonate is also low and PCO2 is also low. So it is not mixed, rather simple, but with compensation. So let us see how much compensation is expected. So for drop of bicarbonate by 10 from 14 to 20, 24 to 14, we expect pH fall 0.16. That is 0.1 change for 6. That is for 10, it is the change is 0.16. So the expected pH will be 7.40 minus 0.16, that is 7.24. But the actual pH is higher. So it is not fully compensated. Okay. So it is partially compensated. That much we can say. But how much is expected PaCO2 in these cases? So it should be 1.5 into bicarbonate plus 8 plus minus 2. So bicarbonate is 14. So the after calculation, the expectation will be in the 27 to 31, same as measured value. So simple metabolic acidosis with partial compensation, which is compensatory respiratory alkalosis. Okay. So these way we have to calculate compensation of the by the additionally in case of metabolic acidosis by the PCO2 or in case of respiratory acidosis by the bicarbonate. So this is the how we decide the flowchart. First acidemia or alkalemia, then if the bicarbonate decrease metabolic acidosis, and if the bicarbonate increase then it is metabolic alkalosis, then increase PCO2 respiratory acidosis, decrease PCO2 respiratory alkalosis. The common presentation is high expected PCO2 with metabolic alkalosis, acidosis, so simple metabolic disorder. But if it is high PCO2 with metabolic acidosis, then it is mixed disorder. This is the low PCO2 with metabolic acidosis is mixed metabolic acidosis and respiratory alkalosis is rare. Similarly, the other portion are these two are the common etiology, either in the mixed presentation or in the simple presentation. Next is to calculate the anion gap if there is metabolic acidosis. So anion gap is it is the difference between unmeasured cation and unmeasured anion. It is increased when the acidosis, metabolic acidosis, is due to accumulation of some non-volatile acid. So we can have acidosis due to perfusion failure. So in those cases, lactic acidosis is there. So that is the accumulation of acids. Or due to some other mechanism where H plus ion is increased. So or accumulation of some non-volatile acids. But in some cases where there is loss of bicarbonate and which is compensated by increase in the chloride, in those cases there should be acidosis, but there should be metabolic acidosis, but there should be no anion gap. So metabolic acidosis can be of two types. Either it is with normal anion gap or with a high anion gap. So how we can calculate? So it is the amount of sodium ion minus chloride plus bicarbonate together. So it is reflecting the unaccounted anion composition of the ECF, that is the accumulation of non-volatile acids anion. So normal value is 8 to 12. So corrected anion gap has to be calculated if there is hypoalbuminemia. So increase anion gap, is possible when the anion gap is more than 15, when there is addition of strong acids, which is not compensated by chloride. So in these cases, the examples are lactic acidosis as a result of inadequate tissue oxygen, which is very often seen in NICU in case of birth asphyxia, in cases of perfusion failure, shock, and so many other cases. In case of acute kidney injury where the acids are accumulated, in case of inborn error of metabolism, late onset metabolic acidosis, ketoacidosis in large protein load of TP and especially with faulty composition like extra cysteine in the amino acid composition. So in these cases, we can have a high anion gap metabolic acidosis. So anion gap calculation is very much required. But in normal anion gap acidosis, it is normally happening due to bicarbonate loss, either due to renal causes like RTA or use of acetazolamide, or due to GI loss, which is very often seen in case of diarrhea. So here bicarbonate is low, but chloride is higher, and so anion gap is compensated. So there is normal anion gap. So the etiology can be differentiated on the basis of anion gap. So this is about metabolic acidosis. Lastly, we have to determine the status of oxygenation. It is already has been discussed. So there are PaO2, P alveolar O2, and alveolar arterial gradient and the ratio. So in analyzer, we will have some alveolar arterial gradient value, and we can estimate A due to, which I am not going in details, already it has been discussed, and on the basis of that we can understand whether the baby is having normoxia, uncorrected hypoxia, degree of hypoxia, and hyperoxia. Hyperoxia is very dangerous because we have very premature ELBW babies and very potential to develop ROP. So more than required oxygen is more than dangerous than hypoxia. So some special situation where temperature correction, we have already discussed in the very beginning, in the machine, automatically there by default estimating everything, calculating the temperature as 37.37 degree. But in some cases where in situations where the neonates is having therapeutic hypothermia, where the neonates having blood samples in the body fluid or body blood at the temperature of 33.5 to 34.5 degrees centigrade when the baby is having therapeutic hypothermia. So in these cases, should we correct this sample to 37 degree? Evidence is not that clear. And in these cases, if we correct the samples with the machine fed values of 37 degrees centigrade, it may not reflect the true acid bed changes because the correction of temperature will change PCO2 of 6 millimeter mercury lower and PO2 of 15 millimeter of mercury higher in this type of temperature difference. Next is the value of lactate. Normally, it is not recognized as its traditional blood gas value, but it is very important because it signifies the result of ongoing anaerobic metabolism, and which is happening due to tissue hypoxemia and poor perfusion. So normal lactate in term neonate is less than 2 millimole per liter, and we can have arterial, venous or capillary values calculated with good correlation and can have a calculated lactate value in newer blood gas analyzer. Most of the cases nowadays machine are giving lactate values, and if the blood is having very free flow, not squeezed sample, those lactate values are more or less reliable. But another thing is very important, the sample should be done within 50 minutes of sampling, otherwise the lactate values will erroneously increase. So it is very much useful in case of assessment of perfusion status of newborn. Another important thing is that some blood gas machine additionally uses co-oximeter along with it, and they can estimate various parts of the hemoglobin like oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, methemoglobin, and so many things. And they can directly calculate the ratio of oxyhemoglobin and deoxyhemoglobin and can give rise to very accurate presentation of arterial oxygen saturation, which is very much reliable, even more than the pulse oximeter SpO2. So if the sample is accurate, arterial sampling, then it can have a reliable SaO2. But the sample is not arterialized, capillary or venous, then it is not reliable. So if the machine is having co-oximeter along with that, it can have additional saturation of blood saturation of hemoglobin as a report along with the strip. So these are the some strip. In the left corner, we can see a strip showing pH of 7.266. So it is showing acidosis. The next point is PCO2. It is showing very high. So it is primarily respiratory acidosis. Then we are matching with the bicarbonate. It is again high. So it is bicarbonate and carbon dioxide are going in the similar direction. So they are in the representation of simple acid-base disorder, primary respiratory acidosis with compensation by metabolic part, but pH is not coming to the normal, so it is partially compensation. In the right strip, the pH is again 7.31, just below normal, whereas PCO2 is 35, just on the lower range of the normal, whereas bicarbonate is very low, 17, which is below cutoff. So the pH is matching with the bicarbonate, where it may be, so it is primary metabolic acidosis. We have to see whether there is any perfect respiratory compensation is at all there, or it is have some along with some mixed disorder or not. So it is an example of metabolic acid disorder primarily, and left one is an example of primary respiratory acidosis disorder. Now coming for, we have the time for some example as well as some exercise. So the first example, pH is 7.26. Everyone, the participant are requested to go by their own calculation, and they can then match with the values given at the end of the presentation. So pH is 7.26, PCO2 is 56, and bicarbonate is 24. So PO2 is 55. So in case of PO2, it is normoxemia. In case of bicarbonate, it is coming in the normal range, but carbon dioxide is in the higher range. So it is respiratory acidosis. But there is no compensation because bicarbonate is not changing. So there is no compensation, respiratory acidosis, and it is simple disorder. Coming to example 2, it is alkalosis. PCO2 is 28. It is very much lower than the normal, and bicarbonate is 22. So we can see it is at the lower range of the normal, but PCO2 is showing the lower value. So it is respiratory alkalosis, and slightly oxygen is higher. So it is higher of hyperoxemia. Again, there is no compensation. That's why pH is very much high, and it is respiratory alkalosis. Example 3, here pH is 7.38, PCO2 is 76, bicarbonate is 42. Here PCO2 is higher, but pH is within the normal range, 35 to 45. But here PCO2 is higher, so it is primarily respiratory acidosis. But what is happening to the bicarbonate? Sorry, it is bicarbonate is showing what is happening to the bicarbonate. It is showing high bicarbonate. So there is some metabolic alkalosis. So it is primarily respiratory alkalosis because it is the pH is more towards the lower range. It is in between 7.35 to 7.45. So it is lower range, nearest to the lower range. So it is, I have to call it respiratory acidosis is the primary thing, and it is compensated near normal with the bicarbonate, which is metabolic alkalosis. Again, here is normoxemia. Example 4, pH is in the acidotic range and bicarbonate is very high. So it is primarily as metabolic acidosis. But PCO2 is also high. So PCO2 is showing alkalotic range. So there is compensation, but pH is not fully compensated. So there is primary metabolic acidosis, simple disorder, compensation is there with respiratory alkalosis, but it is partially compensated. Again, it is metabolic alkalosis, but no compensation. it is metabolic acidosis because pH is lower, nearest to the lower value, but bicarbonate is lower than normal. So it is primary metabolic acidosis, but pH is compensated. So that is primary metabolic acidosis compensated. Again, it is compensated, but PCO2 is dangerously high. Respiratory acidosis, compensatory metabolic alkalosis. Respiratory alkalosis, because it is not beyond normal value, but it is towards the higher range. So it is primary disorder is alkalosis. So it is respiratory alkalosis because of the bicarbonate is low and PCO2 is also low. So again, it is primary disorder with compensation, but fully near normal compensation. Example 9. It is pH is 7.35, PCO2 is 42, base excess is -2, PaO2 60, PCO2 is bicarbonate is 23. So it is an example of normal ABG. So this is all about the example of primary acid-base disorder and some compensation. Example 10 is another disorder, primary respiratory acidosis, but it is uncompensated. Coming to the last 3 examples, here pH is 7.20. So it is acidosis, PCO2 is higher as well as bicarbonate is also higher. So both of them are going to the opposite. Bicarbonate is lower, so they are going to the opposite direction. So it is a mixed disorder and pH is dangerously low, but lower than the normal. So it is mixed disorder, both respiratory and metabolic acidosis. So there is less chance of compensation. Strip 2, it is 7.28, PCO2 is high, 55, respiratory acidosis with metabolic alkalosis. Here pH is coming to the normal range, near normal range. So there is some metabolic compensation. So it is not a mixed disorder, it is primary disorder with compensation. And last one, PCO2 is also low, bicarbonate is also low. So it is again metabolic acidosis with respiratory acidosis, but with some compensation. That's why pH is become low. So it is example of mixed disorder, but with some compensation. So you can have an idea whether with the formula of compensatory change of each values, whether the compensation, how much compensation is expected and how much has been happened in these cases. So this is about the mixed disorder. So last, spot the diagnosis. A baby is there for a prolonged period in the NICU with a PCO2 of 45, but bicarbonate is 38 and pH of 7.51. So what is the condition? So baby is having a alkalosis. So this is a very common scenario in case of ELBW, staying there for a prolonged period with a prolonged ventilation, a prolonged non-invasive ventilation and having BPD or CLD. And it happens the baby sometimes is so much on respiratory dependent on ventilator or non-invasive or invasive, baby requires in extreme situation some amount of diuretic. And if the baby is erroneously or over enthusiastically used with diuretic, this sort of metabolic alkalosis, which is very rare in case of normal scenario, may happen in our NICU. So metabolic alkalosis is mostly seen as a compensation due to either chronic respiratory acidosis, and it is more often happen or accentuated in the background of respiratory acidosis if the baby is having chronic diuretic therapy or hypochloremia, or in case of some surgery patient with having recurrent vomiting with chronic drainage of the gastric secretion through ileostomy or colostomy, or may have some mild metabolic alkalosis after exchange transfusion when excess anticoagulation like citrate are used for high volume exchange transfusion, which is metabolized to give rise to the some alkalic like base in the blood. So that will give metabolic alkalosis immediately after exchange transfusion. So this is another scenario which we sometimes encounter as a some special situation. Again, another cases, it is the baby, small baby, preterm baby, delivered in a district hospital where there is no respiratory support or not that classical standard resuscitation has been tried. So when the baby was referred to an NICU, the baby is showing pH of 7.62 with a PCO2 of 60. That obviously means the baby is having high PCO2 with a respiratory acidosis. So in a case of RDS without any support, in an extreme prematurity, baby may have this sort of initial blood gas parameter. But why there is any bicarbonate is so high? This is because still in some cases there is a chance of giving erroneously bicarbonate at birth as a part of resuscitative attempt when the baby is having poor drive or baby is limp at birth, whether it is term or preterm. So as a result of that inappropriate bicarbonate therapy, baby is having high bicarbonate in the blood. So this is not very much seen nowadays, but this is a possibility. So just to summarize with all these things, we want to how to interpret a ABG strip. First, we have to look at the pH, whether it is acidosis or alkalosis. Then we have to see at the status of carbon dioxide and bicarbonate, whether it is respiratory acidosis or metabolic acidosis or respiratory or metabolic alkalosis. Then we have to see if the acidosis and alkalosis are going, PCO2 and bicarbonate change are going in the same direction. There is compensation with simple disorder. But if they are going, the change is in the opposite direction, they are showing the combined disorder, mixed acidosis and alkalosis. And lastly, when we interpret an ABG, we always not treat the ABG strip. We will not treat the machine. We will look at our baby. We will match it. We will correlate it with the associated medical conditions, associated medical therapies, underlying disease, natural history, course, complication, and possibility of having erroneous or error in sampling or in the machines or in the drawing blood sample or in the processing of the or storing of the sample. All these have to be taken into consideration, as well as the previous report, and the series of change has to be taken in the consideration, while we should not judge any individual ABG strip. That's the key how we can make best utilization of an ABG report. So do not forget to look at the effectiveness of oxygenation and to diagnose the metabolic disorder and diagnose the clinical scenario. This is the exercise for the our participant. We will discuss it in our off stations during the workstations, I think, and this will be available as a YouTube or as a PPT, so they can do it at their home. Thank you. Any questions or any comments from our delegates as well as the experts and professors?
Thank you. Thank you. Please stop sharing. Dr. Bijon is probably there.
I could not listen to the whole presentation.
I know.
But some of the key points, I think, what he has highlighted. First and foremost, important thing is that we should know why we should go for blood gas. Second important thing, he has highlighted that when you take the sample should be collected in anaerobic state. One of the most.
So just a minute, my my speaker is not working. I cannot hear you.
Once a resident collects blood sample, that should be collected in anaerobic condition, because if the blood is contaminated with air bubble, the partial pressure of oxygen in the atmosphere around 150 millimeter mercury. Suppose your gas is contaminated with
Yes, sir.
air bubble, then what will happen? If the uh, PO2 is less than 150, it will show more. If it is more than 150, it can show less than 150. So remember one thing: always gas should be collected in anaerobic state. And whenever you are collecting a sample, it should be airtight so that a small bubble should not be there. Or if it is there, you have to expel it out. Second important thing I think he has highlighted, uh, gas should be processed immediately because blood is a living medium. Once it cannot do it, then it will give you erroneous result. Third important thing in the collection of sample is that heparin solution. Dilution should be 1 in 1,000. If it is more than that, what will happen? This all the mm, electrolytes will combine with heparin, so the level of sodium, potassium, calcium will show low. So that is important. Many times we will find in our some blood gas, we will find hypocalcemia and people are treating babies with hypocalcium. It may be because of erroneous sampling or because of higher concentration of heparin. Most important thing is that whenever you are taking a sample, you should know why you are doing, and it should always be interpreted in the context of clinical scenario. In our clinical practice, what we see in day-to-day practices is that most of the time is a baby born with hypoxia, RDS or any type of respiratory distress, they'll be born with hypoxia. And hypoxia is one of the cause of metabolic acidosis. That is why once you get a baby with RDS, initial blood gas will always show pH will be low and metabolic acidosis will there. Sometimes there may be hypercarbia also. And once you ventilate the baby or give some kind of respiratory support, your gas will be normal. Third important thing he has highlighted is that whenever you are finding metabolic acidosis, uh, always think that you should try to find out the cause and you should treat the underlying cause rather than giving bicarbonate therapy. If you give bicarbonate, what will happen? And in our newborn, in very rare scenario, bicarbonate is administered, like inborn rub, metabolism, renal tubular acidosis, etc. In rest of the condition, if there is metabolic acidosis, you have to treat the underlying cause. Like if the baby is born with hypoxia, that means the metabolic acidosis because of hypoxia. You have to correct the hypoxia, not give bicarbonate. Second, suppose maybe there may be anemia, there may be infection. Uh, all this may lead to metabolic, or sometimes acidosalamide therapy can cause metabolic acidosis. So once you get metabolic acidosis, try to find out the cause and treat the underlying cause. Do not give bicarbonate. If you give bicarbonate, what will happen to the baby? You know once you give bicarbonate, the oxygen dissociation curve will shift to the left. If the oxygen dissociation curve shifts to the left, then what will happen? The oxygen delivery to the tissue will be less. So it will cause more harm to the baby rather than doing good. And second is bicarbonate is hyperosmolar. In a preterm baby, it can lead to intraventricular hemorrhage. Third is that he has highlighted about the compensation and he has already done it. One particular point you should remember, compensation, it may be compensated or immediate, but there is nothing called fully compensated because and in the compensation, another important thing is that once there is uh, respiratory acidosis, that compensation starts immediately. Suppose you get a baby with respiratory acidosis, you do a suction. After 30-40 minutes, you take the sample, it will be corrected. But metabolic acidosis to correct, it takes time like 3 to 5 days. Another important point should remember, in case of ALBW or VLBW infant, in the first few days of life, you may get some kind of metabolic acidosis because of renal tubular acid loss, bicarbonate loss. Normally, urine is free of bicarbonate, but in case of extremely low birth weight baby, there may be some kind of loss, and that loss actually should not be treated with bicarbonate. You have to see the clinical scenario. That is important. Another important point nowadays it is highlighted is the lactate level, because even you get good PO2 or good saturation, it may not always tell you that there is tissue is not hypoxiated. If you find more lactate is more, it indicates there is tissue hypoxia. That's why nowadays more modern blood gas machine they are giving lactate level also. So I think Anindya has highlighted all those points. I just wanted to summarize all those points. If any participant has got any questions or query, you can ask in the chat box or you can directly ask to us. I think Anindya will be happy to answer. I
So
think one.
there are two questions. One is, sir, how to differentiate between venous blood gas and arterial blood gas. So I have shown in the slides the venous blood gas is very easy to take, but it is not that reliable. But if we can manage with oximetry and other things, or the other pulse oximetry and non-invasive ways, so we can have an estimate of bicarbonate and base excess, which are most reliable in the venous blood, which is corresponding to the arterial blood. So these two are matching. So we can go with this. But in case of pH, it is slightly lower. And in case of PCO2 is also slightly higher. So in those two values, it will be different from the original gold standard arterial value. So how much value will be different? There is no guideline, and it will be changed depending on the situation, baby's physiology, and so many things. But it can be taken with a pinch of salt, the pH, as well as the bicarbonate and the base excess, if we do not want to puncture the baby's arteries, which is very painful and which is not at all required if we have a good pulse oximetry machine. So in this case, venous blood gas can be very much helpful. And another question is, what is delta anion gap? That is also very new term. So we have told about the anion gap, which is normally up to 12, and more than that is abnormal. So, but if we calculate it as a ratio, that is the change in the anion gap from the normal, that is from 8 or 9, and divided by change in the bicarbonate, then it is called a anion gap ratio or delta anion gap. And there is also a value. If it is less than 0.4, then it is a normal anion gap. If it is more than 0.4 to 0.8, it is equivocal. If it is a more than 0.8, then it will be high anion gap, severe metabolic acidosis. So it is just a change of the term and nothing like of that. It is most important what is the clinical scenario. A baby with diarrhea or RTA is very much evident with a baby different with a baby with a lactic acidosis like asphyxia or pure metabolic acidosis or something like that, or IM. So anion gap may be a useful tool, but the clinical scenario is the ultimate.
So I think another point he has highlighted about the base excess. So whenever I see a gas, the easy way to interpret a gas, just see the pH. If the pH is low, that means there is acidosis. It may be metabolic or it may be respiratory. If the pH is higher than more than 7.45, it may be respiratory alkalosis or metabolic alkalosis. He has highlighted if the base excess is more, then means it is always metabolic acidosis. So if you get a pH is less than 7.35 and base excess on the higher side, two things is confirmed. One is acidosis and second is metabolic acidosis. Then you see if the metabolic acidosis is there, then bicarbonate will be low. If the bicarbonate is low and the COD is also in the same direction, that means there is a
simple disorder with compensation.
Compensation, and you can see how much compensation is there with that all these formulas, and he has told. If it is going in the opposite direction, that may be a mixed disorder. In newborn, what are the common respiratory blood gas problem we get? One is
respiratory acidosis.
Metabolic acidosis. Metabolic alkalosis is very less, and respiratory alkalosis is also less. Respiratory alkalosis you may find in neonate in a ventilated infant when the babies are
hyperventilating.
So if you have got any more questions, you please ask. You can unmute yourself and you can ask directly. Any question?
Or you can send your question to the WhatsApp group, and the
WhatsApp group,
respective question will be answered by the respective faculties.
Yes, sir.
So thank you, Dr. Anindya, Dr. Bijon, for their valuable inputs and nice presentation by Dr. Anindya. He has elaborated our blood gas analysis in a nice way, and every parameters had been explained very nicely, and Bijon has summarized very beautifully. So If anybody had any question, they can write down to their WhatsApp group for the ventilation of the neonatal workshop. So, with these few words, if house permits, then I can close the session with
Surely, sir.
saying good night to all.
Good night,
Thank you,
sir.
sir.
Good night.
Thank
Good
you.
night. Thank you, Anindya.
Yes, sir. Thank you.
Mhm.